what I like to focus on and try to reiterate to the families is that we want a child to breathe very well, and we want their respiratory health to stay good despite whatever issues are going on. We want them to continue to develop, and that means develop their oral feeding skills if they're, affected negatively by whatever is going on. And we want them to continue to grow.
There are patients who remind us that anatomy does not work in silos, that airway affects feeding, feeding affects growth, and reflux impacts the lungs. Suddenly, one small child has 3 subspecialists and a very full calendar. Aerodigestive medicine lives at the crossroads. And while multidisciplinary teams bring great expertise, primary care providers are co-managing these patients. They are fielding the "is it normal" question. They are tracking growth charts, and they're advocating for patients and helping families make sense of what they might perceive as conflicting recommendations. This is Charting Pediatrics. Joining us to discuss what meaningful co-management looks like are 2 experts, Dr. Emily DeBoer and Dr. Todd Wine. Dr. DeBoer specializes in pulmonology here at Children's Colorado and is a professor of pediatrics. Dr. Wine is an ENT specialist and is an associate professor of otolaryngology at the University of Colorado. Emily and Todd, welcome to the podcast.
Thank you.
So delighted to have you. Let's just jump right into this. How would you describe the perfect aerodigestive patient to a primary care provider?
Well, on paper, we say that children who would benefit from aerodigestive care have interrelated diagnoses in usually complex breathing, swallowing, growth problems, just like you said. They're more than just the kids who have all 3 of our specialties separately. They would really benefit from the 3 of us talking together in the same room with the family to make a plan so that their current plan isn't working great.
And who actually is on the aerodigestive team? I think it's more than just 3.
Yeah, so that's one thing I wanted to point out is that it is more than just the doctors, and that's really I think the key to the team itself is the other parts. It's the glue that holds it all together. And that's the therapist. So it's speech and language pathology, occupational therapy. We are, when we're lucky, we also have social work usually helping us out because these can be complex situations. And then anesthesiology is involved as well, because we do have a component of the practice where we are putting children under anesthesia.
And we have dietitians,
yes,
nurses, nurse coordinators,
nurse practitioners,
special scheduling. Takes a lot of us.
That's a fabulous number of people. So I love one of the things that you said, Emily. You said that, rather than seeing you and Todd separately, you bring it all together in one room. How does that happen? Do you see them sequentially as your own service and then come together? Or how does this whole act play out?
The different aerodigestive programs across the country do things differently. Here at Children's, the patients come to the multidisciplinary center at Anschutz. They have a very long visit, and they see each of our team members independently. So we're each going to ask the parent and the child, or the caregiver and the child, what's the most important thing that aligns with our diagnoses? How does it interrelate? And then we talk all together at the end of the visit.
So it's everybody sequentially, and then you have the grand performance, the finale act, and you put it all together.
For the most part, I do think that there is like a therapy dietitian tandem that do see the patient usually at the same time, or they kind of overlap for part of their visit. And then usually the way we have it set up is that there'll be a speech and language pathologist or the occupational therapist. They're managing the swallowing aspect of things. And so both of those clinicians don't see a particular patient. It's usually one or the other of those.
And are there any patients who would benefit, say, from seeing GI, pulmonary, and ENT separately versus having a whole aerodigestive team? Or is that too old school?
It's not old school. I think sometimes there can be advantages when it might be difficult to get in to the clinic if there's a more urgent need. And then sometimes the long visit may not be the right fit for that patient and that family. And so in that situation, especially if they're a local family, setting up shorter visits, but more visits could be an advantage.
And there's certain diagnoses. Asthma is well suited in asthma clinic because we have asthma specialists and other team members to really focus on asthma. Or I hear from Todd a lot that checking on ears isn't the easiest thing to do in aero clinic versus in ENT clinic.
Yeah, so I think the one thing that we do run into sometimes is that folks will assume that the clinic is designed to just see any kid who has any GI and happen to have ENT problems and have pulmonary issues, and then they should be seen in that clinic. When the real benefit is when they have those things are interplaying and not just like separate diagnoses.
So one thing you just mentioned, Emily, was the kid with asthma being seen in an asthma clinic. What if that kid has reflux that's impacting their asthma as well? Is that two separate visits?
Those are great patients. So asthma and worried about, is it the reflux or is it dysphagia or is it esophageal dysphagia? Why is the reflux affecting asthma? Those are great patients for us to see. Or are they obstructing in their airway and causing their reflux? So often Todd and I try and take responsibility. If the reflux is bad, is it our system's fault?
And how do most patients end up coming to you? I would suspect that some are complex premature kids that might come from a NICU situation. But then what does a pediatrician or a family medicine doc look for in the office that might say, aha, this kid would benefit so much more from an aerodigestive program?
I think that, I try to think about it in terms of like, what are really common things that pediatricians are seeing a lot? And that's like, they see a lot of babies that, might be termed a happy spitter, and so that's not an issue. But like, if you're seeing that and there are growth problems or breathing problems or noisy breathing or breathing problems where they need oxygen longer or they're having retractions and they're just not responding to the typical or like the typical infant, then that's when the PCP should be thinking, I wonder if there's something a little bit more going on here. Why don't we have the aerodigestive team take a look at them?
And what does a perfect partnership look like where aerodigestive and the primary care provider are co-managing a patient? If you could describe it in the best possible scenario.
Well, the perfect relationship may be the family got great recommendations from us that are working and everything's going smoothly, right? But the patients where the recommendations are hard or they're hard to implement or they didn't work the first round, the family and the PCP, we really depend on them to reach out and tell us, we couldn't do it because of XYZ, or we did it and it didn't work. And how do we get back in to make better recommendations? Can we do that in the PCP's office by guiding over the phone, or do they need to come back in and see certain parts of our team? I think it's communication of what's not going well.
What do you think, Todd?
Yeah, I think that the perfect relationship in co-management is really has to involve communication, and that's really the key. Is making sure that it's an open line of communication where they feel free to contact us and know how to contact us, and we're helping them troubleshoot, because it can very much, and it's very, probable that it could happen where we start with a plan, the family enacts the plan, they follow with the PCP, the plan might be a little bit confusing, and they need to, so the primary care physician is assessing the situation and thinking, I think there might have been a discrepancy, and then they're coming back to us and letting us know that there is that issue.
So obviously they can make some medication changes on their own, not necessarily having to call you. But if it gets to be a little too complex or not working, is that a good time for a follow-up?
Yeah, I mean, I think that it is always a good time. It's a good time to communicate, because I think, probably the highest percentage of the population that we take care of happens to be the population of children who have dysphagia, and that can be managed in many different ways. And oftentimes, the plan that we may have the child on, at least my opinion, I feel that usually physicians and primary care providers will defer to us in a lot of those situations. And so they won't necessarily adjust the medications. That's why I think the communication key is very important.
I think these families carry such a heavy load, thinking of all the doctors that are needed to take care of their kid who they just want to grow up and be absolutely normal. So there's a lot on their shoulders. And I wonder if there's any insight from clinic you can share that might not be obvious, thinking that you do have a social worker there and there may be other problems below the surface that we don't know about.
Yeah, I think one of the big challenges that we see in clinic that we feel a lot of pressure. And the pressure that we feel is because almost like the clinic visit in our role in managing the problem is very it's very big, in the sense that they're hoping that our clinic visit not just identifies the problem, but solves the problem in a lot of times, and solves it in a way where it works very quickly. And so there's, I think, sometimes a misunderstanding of what we can actually achieve. And that's the hard part, because we see that when we're having these interactions with the family, and we know what we can provide. And while it is very good, we also know that it's limited compared to the expectations sometimes. And that results in some tough moments in clinic. And that's where our social workers really help shine, because it can be highly stressful for everyone involved. And it's not just the families and the children, the patients, but it's also us, and sometimes we walk out of a room and we know that it didn't go like we wanted it to go. And we're trying to say, how can we get back on track? And it's easy to get distracted, to get, the whole clinic gets kind of going sideways in those moments. So it's a big challenge.
On the flip side, it must be so satisfying when it does click and it does go right, and you can feel that impact the whole team. Uplifting moment, maybe.
It is. I mean, I think in those moments, though, it's not usually like right away in clinic. Mm-hmm. It's usually months and years down the road. And I think that's how we know we're doing a good thing. And I think the other way we know too is that the clinic has continued to grow. throughout the years and expand in ways that are difficult for the system to keep up with.
So I can imagine that when one of these kids gets sick, it really does derail an awful lot of things. Let's just say right now we happen to be sitting in respiratory season. We know there's a lot of RSV out there, a lot of COVID, a lot of influenza A and B. What happens when these kids get sick? How derailed do they end up getting?
Well, you see a lot of our children in the emergency room.
I do. Thank you for sending them to me.
A lot of our children get admitted to the hospital. And maybe that their plan is going well, but they're just so high risk. They have low reserve, and RSV pushes them over the edge. And we don't necessarily have to change their plan if things are generally going the best they can, or the plan's not going great. And you started really talking about not all of our children have atypical anatomy, but some do. So we're the medical home for children with congenital esophageal atresia and TEF. And so we will follow those patients long-term because of their anatomic challenges that contribute to complex pulmonary and swallowing problems. And they can get admitted with RSV and asthma. And we try really hard to make sure that the teams understand how their esophageal dysphagia and their feeding trouble can lead to aspiration and increase the risk. And sometimes those diagnoses are really challenging, and they might sound the same way as an asthmatic with typical anatomy. So to try and educate the family and educate the team on how these kids are different than other patients that we see.
Do you have any tips or tricks you can share with community providers on how to manage daycare and feeding plans and those types of everyday activities?
So this is a great place to shout out the Aerodigestive nursing team. The Aerodigestive nursing team, which is based in the Breathing Institute and shared with DHI, knew that feeding plans in daycares and feeding plans in Colorado schools was a real problem. And it's partly because it's mostly not medication-based. So we have asthma action plans and seizure action plans and all kinds of medication-based action plans that go through the school. And thickener is a food additive, not a medication. And so true medical-based recommendations on feeding plans didn't fit the mold. And our nursing team shared the work with the Children's Hospital school-based nursing team, and they have completely redone the feeding recommendations for Colorado schools and have educated so many school nurses on thickening and feeding plans to make sure they understand the recommendations. So we have those resources, and our team can lead that if they come to the dysphagia clinic. But if your dysphagia is managed elsewhere, then we can make sure that your team has the right resources, and our team will reach out to the school nurse if they need help to implement it in the school.
Now that is a great tip, I must say. You talked about that sometimes you're having trouble managing the volume of patients that you're seeing in our aerodigestive clinic. Give me a picture of what's going on in the country and even the world as to our aerodigestive clinics increasing overall.
I think it's every aerodigestive program is a little bit different in the makeup of their clinic, how often they have their clinic, what department houses it. And so it's a hard question to really drill down on. I would say within the Aerodigestive Society, it is an area where there's a lot of interest in those of us who do this work. And, so I think that they have similar challenges, but everyone's challenges are a little bit different. But it is, I think, a growing field overall and a growing level of importance for kind of its place within managing of a lot of these patients.
All right, here's a nerdy ER doc question. Since you have anesthesia on your team, can you just do like a triple scope in clinic? Or I see you shaking your head, Todd, that's a separate appointment outside of the clinic.
Yeah, so that's where for the out-of-state patients, we're often trying to coordinate and optimize their time. So a lot of times they might be having a clinic visit on a Wednesday. They might be having some imaging studies on Tuesday, including a swallow study, working with the therapist for the video fluoroscopic swallow study on a Tuesday, and going to the operating room on a Thursday for panendoscopy with the team under anesthesia. And so that is how it takes place for like the patients who come from further distance. For the local patients, and for a lot of patients, even some who come from distance, we know too that sometimes, and this is where kind of the triage visit maybe ahead of time can be helpful, is because we do have to recognize that some of these patients may not be quite optimal for anesthesia. And so it's very important to have anesthesia involved to help with that assessment and to say, like, if they're not optimal, what do we need to do to get them to be optimal? Because we can, while these scopes are just diagnostic, they can be quite challenging to get some of the kids through. And so we do, that's why we have the anesthesia team involved with our clinic.
So I can only imagine how frustrating it is for a family to have traveled a great distance, take time off from work, and only to have their procedure canceled. What are the next steps after that happens? And I'm sure a phone call is made to the primary care provider.
Todd already talked about how much pressure the family can be under when they come to the visit, and we feel to help them. And when a patient is sick at the time of their scopes, when they maybe waited a long time, and they're already high-risk patients, and they're sick a lot of the time, or they waited a long time, they traveled a long distance. So we really anchor on, we are doing scopes when it's safe for you and your family, and we are doing scopes to get as much information as we can. And so if you're sick with RSV, scopes will look very different. So we have to make sure we get good information. And then we really anchor on, we can make changes, medical changes, without the results of the scope. So if you're in our clinic, we can see you and make recommendations and make plans to hopefully get you healthier for next time. Or we can help over the phone of what else can we do, what's the optimal time for rescheduling and anesthesia. And really, it's the whole team that helps with those kind of things.
And what's your overall goal in the program? How do you define success?
To me, I view like our overall goal is to help optimize each child who comes through the program. And what I like to focus on and try to reiterate to the families is that we want a child to breathe very well, and we want their respiratory health to stay good despite whatever issues are going on. We want them to continue to develop, and that means develop their oral feeding skills if they're affected negatively by whatever is going on. And we want them to continue to grow and be nourished in whatever way they possibly can. And it's focusing on those goals that I think is really important to help the child get to be the infant or the young child, the toddler who's having trouble, to the successful, first grader, second grader, where these problems are behind them.
I love how you frame that, both of you. And thank you so much for being on Charting Pediatrics today, sharing your knowledge. And I think I've learned so much about aerodigestive, as have everyone who has listened. And to all of our community providers, thank you, and keep on keeping kids safe out there.